Hi guys, so I wanted to have a lecture on syncope today and to now help you guys understand the effort that is put in behind these videos because we did the studying together and then this is the final product. Grab your piece of paper, grab your pen, and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at syncope. If you haven't yet subscribed to the channel, please subscribe to the channel. Hit the bell notification icon to be receiving notifications of such videos every time I post. Tell a friend to tell a friend. Drop a comment, drop a like. Subscribe to the channel if you haven't. Hit the bell notification icon to be receiving notifications of such videos every time I post. Here's a warm-up question. A 25-year-old girl presents with episodes of syncope. Take a history and ask important questions that will enable you to make a diagnosis. List the questions, don't write an essay. This could be a possible OSCE station in your physical OSCE stations or even on a projected OSCE station. So what exactly is syncope, which is also referred to as fainting? This is just simply a transient loss of consciousness and postural tone. Now most commonly, it's going to be due to global cerebral hypoperfusion, so the brain is not receiving oxygen. And remember that the brain is a very selfish organ. When it's not receiving oxygen, it will turn off its centers and then eventually you lose your tone, you will fall down to the ground, and so that you can lay flat and gravity isn't affecting you such that the brain can become reperfused. Now remember that a faint is going to be characterized by rapid onset, short duration, and a spontaneous recovery. And these fainting may sometimes occur suddenly without any symptoms, or they may be preceded by certain symptoms of fainting, which is known as a pre-syncope. So these pre-syncope symptoms include lightheadedness, dizziness without true vertigo, a feeling of warmth, diaphoresis, which is sweating, nausea, visual blurring, and occasionally there may be some proceeding blindness that may be there. So the pre-syncopal symptoms actually do vary in duration and they may actually increase in severity until someone loses consciousness, and they may resolve prior to loss of consciousness if the cerebral ischemia is corrected. Remember that syncope can occur as a single event or may be recurrent. If you have ever fainted before, I have, you would know what it feels like to actually faint. And it should be distinguished from other causes like seizures, and this can be done by taking a careful history, including an eyewitness account, as well as a physical examination. And remember, in all cases of syncope, the physician must always rule out other causes because massive internal hemorrhage, cardiac arrhythmias, myocardial infarctions can all be causes of syncope. Remember that it's going to be accounting for 3% of all emergency room visits and 6% of all hospital admissions. And syncope has a risk of injury to an individual, especially in adults. It may result in femoral fractures. In the elderly patients, actually, a sudden faint without any obvious cause should be suspicion for a complete heart block. You should suspect a tachyarrhythmia, even when the findings are negative at the time of presentation. Remember that falls without loss of consciousness are very common in extrapyramidal disease, and the term collapse is actually non-diagnostic, and generally we should avoid using the term collapse and saying the patient collapsed. We actually reserve it. From where I used to work some time back, we used to reserve collapse for a patient that had actually died. So what are some of the things to consider? Remember that the differentials that are going to be there in relation to syncope are going to include seizures, which is a sudden, uncontrolled electrical disturbance in the brain, transient ischemic attacks, which are in the background of cerebrovascular accidents or strokes, or it could be hysterical fainting. So this is an attack which is usually unintended, or rather unattended by outward displayed anxiety, and then of course there'll be lack of change in the pulse, blood pressure, or even the color of the skin, and even the mucous membranes that distinguishes it from a vasodepressor type of faint. This is of course someone who's being hysterical, someone who's faking it. So what are some of the common precipitants? You may have prolonged standing because all the blood is pooling in the legs. You may have fear, you may have venous section, you may have pain. And remember that syncope almost never occurs in the recumbent position. It's very rare that you would faint when you're laying down. Most of the faints usually happen when someone is standing up. What's the pathophysiology of the condition? Remember that here there is a sudden impairment in the brain metabolism, And usually it's brought about by hypotension, it's brought about by a reduction in the cerebral blood flow. Remember that there are several mechanisms that are going to be pretty much adjusting the circulatory system to the upright position, and they are keeping the brain perfused. And at any given moment, approximately 3/4 of the systemic blood is actually present in the venous bed. And anything that is interfering with the venous return of this blood back to the heart will therefore reduce the cardiac output. Remember, from our Frank-Starling phenomenon, the venous return is going to be matched to the cardiac output. The more blood that you load in the heart within physiological limits, the harder it will contract and it will push out this blood. Now remember that if you have cerebral blood flow, which is going to be maintained, it's going to be maintained as long as the systemic arterioles are vasoconstricted. So when these adjustments actually do fail, there is some serious hypotension that's going to be resulting. There is cerebral underperfusion that's going to be there, and less than half of the normal perfusion of the brain, then that's how a patient is actually going to undergo a syncope or a faint. So normally the pooling of the blood in the lower parts of the body can actually be prevented by several things. There is what is known as pressor reflexes that induce constriction of the peripheral arterioles and the venules to push blood, and also offer total peripheral resistance and to push blood back to the heart. Then of course there are some reflex accelerations of the heart by means of the aortic and carotid receptors. This is the baroreceptor arc. If you actually get up too fast, you may sometimes feel like your heart is racing in that particular moment if you pay close attention. And then there's also improvement of the venous return to the heart by activity of the muscles in the limbs. Remember that veins are going to be existing between muscles such that when the muscles contract, they push blood back to the heart. So all these mechanisms are preventing pooling of blood in the peripheral system, because if blood pools in the peripheral system, this can easily lead to someone actually fainting. What are the stages of syncope? They are divided into 3 predominant stages, just like with seizures, where we have the pre-ictal, ictal, and post-ictal, but we don't call them that in this case. We're going to be calling them the prodromal or the pre-syncope. You may or may not have these symptoms. Then you have the syncopal attack or the blackout, and then you have the recovery afterwards. So the pre-syncope is usually brief. There is dizziness, lightheadedness, there is sometimes nausea, sweating, there may be a feeling of heat, and even visual gray out. It's like someone is slowly turning off the lights, and the sounds are also slowly dimming out, and sometimes they may even become quite loud. Then the blackout comes. So usually you lie still, and there may be some jerking or even twitching movements that can occur, and sometimes these are mistaken for a convulsion. The patient often appears pale. Incontinence of urine and feces can sometimes occur. Thank God it did not occur when I fainted. And is actually not even a good discriminator of distinguishing between seizures and syncope. Then the recovery is rather rapid and usually takes about a few seconds, and this may be followed by a feeling of general fatigue as opposed to the post-ictal drowsiness and confusion that we see following a seizure. Now, what's our approach to a patient that has just fainted? What's our history? So we want to take the events before, during, and after the syncope. What was the patient doing? Were they performing any bowel movements? Were they urinating? Were they standing? How long were they unconscious for? Was there any prodromal malaise, nausea, pallor, diaphoresis, weakness, any loss of muscle tone? Did the patient recover once they were flat or recumbent? Was there any urinary or fecal incontinence? Is this the first episode? And what was their last meal? Any symptoms of anemia, palpitations, dizziness, headaches? And remember that severe anemia at any age can actually cause syncope. The precipitants, was there any acute or anticipated pain, emotional stress, fluid loss, or any bleeding of some sort, obstructed venous return, intense activity in the heart like a palpitation, or any other cardiac symptoms that may point us towards arrhythmias and all those things? Was there any prolonged standing or postural hypotension? What's the past medical history? Have they fainted before? Do they have any cardiac conditions, especially arrhythmias? Do they have features of anemia? Do they have diabetes mellitus? Have they been found with any of this condition? Of course, another thing that I didn't add to this, which is very important, is a pregnancy test. The last menstrual period, and ask this patient if they are pregnant or they have taken a pregnancy test. If they haven't, it's very important that you do take a pregnancy test after you examine this patient. Then the past drug history is going to be including non-prescription drugs, especially recent ones, diuretics, antihypertensives, or polypharmacy patients. Then family history of syncope and a social history of which is the occupation. Maybe they're a soldier and they were standing for some time, smoking and alcohol drinking. When you perform a physical examination, the examination is usually normal in a vasovagal syncope. I'll talk about what that is very shortly. You look at the vitals, the heart rate and the blood pressure in the supine position, in the standing position, as well as in other positions. Then after that, you do a full cardiovascular examination, checking for cardiac arrhythmias. You do a neurological examination where you may find some evidence of dysautonomia. So that's your postural hypotension, your impaired sweating, your pupillary abnormalities. This may be found in the central nervous system or the peripheral nervous system. You should note that in patients with recurrent unexplained episodes, there should be an attempt that should be made to actually reproduce the anxiety such that you can aid making the diagnosis. You reproduce the thing that is causing them to faint. For example, if it's an anxiety attack, you can induce this by hyperventilation, and of course this patient take these rapid deep breaths for about 2 to 3 minutes and they'll faint. Then if it's cough syncope, then we should reproduce this by inducing a Valsalva maneuver, what is similar to when you are in the toilet and you're about to poop. Then carotid sinus massage generally should be avoided, even in patients with suspected carotid sinus hypersensitivity. Why? Because there's a risk of dislodging the carotid atheromas, there's a risk of a transient ischemic attack, there's a risk of a stroke. Now, the hint is this. Loss of consciousness in a particular situation, such as during a vena puncture, during micturition, or with volume depletion, this is going to be suggesting an abnormality of the vascular tone. Then loss of consciousness without global cerebral hypoperfusion can be caused by certain other things. Epilepsy can cause someone to lose consciousness when there isn't really global cerebral hypoperfusion, the complex partial seizures as well as the generalized seizures. Metabolic disorders such as hypoglycemia, hypoxia, and even hypercapnia. Drugs, this can be either medical or recreational drugs can cause this. Then what investigations are we going to order for this patient? Remember that intensive testing is often fruitless and actually even pointless. You may find out that they actually get a normal investigation back in patients that have actually fainted. Though it may be useful to identify certain risk factors in certain groups of patients. For example, patients that are over 45 years with a history of congestive cardiac failure, those that have ventricular arrhythmias, those that have an abnormal ECG. Then do a 12-lead ECG. This may show heart block, pre-excitations, or even long QT syndromes. Then this actually identifies definitive causes in 5% of the patients and may provide evidence of unsuspected cardiac disease and should be done in almost all the patients that faint. You can order for a HOT ECG. That's an ambulatory ECG monitoring. This is useful in patients that have cardiac syncope, less than 5% of the patients. So an implantable loop recorder is actually occasionally needed for infrequent events with a possible cardiac origin. Echocardiograph should be obtained, especially if you're suspecting that there is a left ventricular dysfunction or valvular disease, or on the history of an abnormal physical examination of the cardiovascular system. Stress echocardiography as well as stress imaging can be done, especially in patients with coronary artery disease, and you should also perform what is known as an upright table tilting test. This is somewhat diagnostic but very low sensitivity. So how do we do this? So the patient is actually secured to a table. Then the table is inclined at a positive 60 to the vertical plane for about 45 minutes. The ECG is recorded, the blood pressure is recorded, and if neither symptoms nor signs develop, then we can give isoprenaline, which is going to be slowly infused, or glycerol trinitrate, which can be inhaled. Then the tilt of the table can repeat it. So you get a positive test if you have hypotension, sometimes bradycardia, and pre-syncope syndromes or pre-syncope symptoms. So this usually is diagnostic for neurocardiogenic syncope. So whenever these symptoms actually appear, you can actually make the patient lay down flat again, and this can reverse the symptoms. So the effect of treatment can actually be evaluated by repeating the tilt test, but it's not always reproducible. Then carotid sinus massage with cardiac monitoring should be completed in older patients without any readily identifiable cause of syncope, or in those with symptoms that are suggestive of carotid hypersensitivity. So a 3-second pause is diagnostic and may actually indicate the need for a pacemaker. Get a CT scan and an MRI of the head, though it's rarely indicated unless if there's a history of head trauma. An EEG can be done and is useful in cases where you're suspecting that this is a seizure, and a chest x-ray in cases of cardiac pathologies. Blood tests include a full blood count to rule out anemia, serum glucose to rule out hypoglycemia, UNEs, creatinine to rule out uremic encephalopathy, HIV, RPR for syphilis, then liver function test, liver enzymes, lipid profile, as well as a clotting profile. What are some of the causes of syncope? Remember that this is transient cerebral hypoperfusion, which is due to predominantly three mechanisms: cardiogenic syncope, neurogenic syncope, which is known as reflex syncope, and orthostatic syncope. I'll begin with cardiogenic syncope. So here, cardiac syncope is as a result of sudden reduction in cardiac output. This is caused commonly by cardiac arrhythmias. So in cardiogenic syncope, there is no warning sign, and it can actually occur in any position, including when the patient is actually laying down flat. And the patient may actually have palpitations, they may have chest pains at the time or even recently. Then cardiogenic syncope is going to be lasting roughly about seconds to minutes, and there is no incontinence. The patient may actually look pale during and after, and they may have a few clonic jerks. The recovery is actually quite quick. The heart rate is between 30 to 180 beats per minute, and do not reduce, these heart rates actually between 30 to 180 do not reduce the cerebral blood flow, especially in a patient who's in a supine position. But if you decrease the heart rate, then the ventricular filling time and the stroke volume increase to maintain the normal cardiac output. And then at higher heart rates of 180 beats per minute, remember that the ventricles are not going to be filling with adequate blood. So this is going to actually be inadequate to maintain the adequate stroke volume. So remember that in the upright position, cerebrovascular disease, anemia, loss of atrioventricular synchrony, as well as a coronary myocardial or valvular diseases, all are going to be reducing the tolerance to alterations in the heart rate. What are some of the causes of cardiogenic syncope? The main big cause is cardiac arrhythmias, both bradyarrhythmias and tachyarrhythmias. Bradyarrhythmias could be due to sinus bradycardia, sinoatrial block, sinus arrest, sick sinus syndrome, especially in sepsis. You may have atrioventricular block, especially type 2 or the second degree type 2, or the third degree resulting in syncope and pre-syncope. You call this a Stokes-Adams attacks. Then they may actually cause syncope if the escape pacemaker rate is actually insufficient to maintain the cardiac output. Then the syncope is often abrupt without any pre-syncopal symptoms, and it recurs several times a day. So patients with sick sinus syndrome actually may have a pause, sinus pauses for more than 3 seconds, and those with syncope due to higher degree of atrioventricular block, that's your Stokes-Adams-Morgagni syndrome, may actually have evidence of conduction system disease. So they may have a prolonged PR interval, they may have a bundle branch block. You may also have some drugs like digoxin, beta-adrenergic antagonist, calcium channel blockers, many antiarrhythmic drugs that do suppress the sinoatrial node impulse, and actually they may actually even slow the AV node conduction. Then you also have tachyarrhythmias. This usually are preceded by palpitations, lightheadedness, and they may occur abruptly. There are no warning symptoms. Supraventricular tachycardia is unlikely to cause syncope unless if there is a structural cardiac disease such as a Wolff-Parkinson-White syndrome, a cerebrovascular disease, or disorders of vascular tone or blood volume, or a rapid ventricular rate. Atrial fibrillation associated with Wolff-Parkinson-White syndrome can cause syncope, atrial flutter with a 1-to-1 atrioventricular conduction rate, then ventricular tachycardia in patients with aortic valve stenosis, even in hypertrophic obstructive cardiomyopathies, are also at risk of having ventricular tachycardia. You may also have some drugs which are antiarrhythmic drugs, even some antibiotics like erythromycin, electrolyte disorders like hypokalemia, hypocalcemia, hypomagnesemia that can actually prolong the QT interval, predisposing to a certain type of arrhythmia which is known as a torsade de pointes, which is a French word. So there are some structural causes, such as valve diseases, especially with severe aortic stenosis, cardiomyopathies such as hypertrophic cardiomyopathies, other cardiac diseases like myocardial infarction, pericardial disease, especially pericardial constriction, or even tamponade, atriomyxomas, which are tumors, congenital heart disease, and even some extracardiac conditions like pulmonary embolism, pulmonary hypertension, and even aortic dissections that may cause cardiogenic syncope. Then the next type is a neurogenic syncope or a reflex syncope. So this is predominantly due to an increase in the vasovagal stimulation. So it's going to be as a result of a reflex drop in the heart rate. Remember, this is referred to as reflex bradycardia, as well as the peripheral vascular resistance. So both the peripheral and the splanchnic, the vessels are dilating. So during the onset, patients are usually standing or sitting, but they're never laying flat in this case, and they may have a brief syncope, pre-syncope signs rather, nausea, pallor, sweating, visual field narrowing. Then of course they do have events of myoclonal jerks, and they sometimes do have urinary incontinence. And the duration is rather brief with a quick recovery. The type of syncope is usually recurrent and commonly precipitated by certain things, maybe a hot or crowded environment, maybe alcohol, extreme fatigue, severe pain, hunger, sometimes even prolonged standing. This, I think, is what I had. Emotional and even stressful situation. Then there are some common faints that may actually occur in normal persons that they may experience. This is the most common type, the neurogenic syncope. And this actually accounts for half the episodes of syncope. They are common in childhood, they are common in youth patients, they are common in pregnant individuals. What are some of the causes of neurogenic syncope? It could be due to vasovagal syncope, which is also referred to as a neurocardiogenic, simple or uncomplicated syncope, or even just the common faint. This is the commonest cause of transient loss of consciousness. It's often due to orthostatic stress, so long-standing, hot weather, or even reduced fluid intake. This may actually be caused by emotional stress like pain, other emotions, seeing blood, seeing needles, and there are 3 P's that do suggest that someone has a vasovagal syncope. Number 1, it's postural in nature, the provocation, and even the presence of a prodrome, the prodrome or the pre-syncope. They may have jerky movements and twitching that can occur. This is often confused with a convulsion, and they do appear pale. Recovery is rapid, and is actually may be followed by a feeling of general fatigue as opposed to the drowsiness. I think I already alluded to this much earlier on. Incontinence of urine and feces sometimes can also occur. I did allude to this earlier on. Then with carotid sinus hypersensitivity or carotid sinus syncope, they have altered heart rate and blood pressure due to hypersensitive baroreceptors, which are found in these areas in the carotid body. Then the syncope on minimal stimulation of the neck can happen, such as shaving, such as having a tight shirt collar. Then you may have situational syncope, which is due to specific triggers, like coughing, a postprandial after eating, micturition, defecation, Valsalva maneuver, even deglutition. Imagine swallowing and then fainting. Exercise, though syncope during exercise often is going to be indicating a cardiac pathology. You may also have glossopharyngeal neuralgia. Now, what about orthostatic postural hypotension? So this is seen in patients that have just stood up. Remember that there is a fall in the blood pressure greater than 20 millimeters of mercury systolic, greater than 10 millimeters of mercury diastolic. It's going to be typically tested by checking the BP when the patient is lying or sitting, then 1 minute after the patient is standing. Then syncope or pre-syncope symptoms can actually occur on standing, and it's worse in the morning. This type of syncope may cause what is known as coat hanger pain, which is the pain that's across the neck, the shoulders, due to the neck muscles being hypoperfused. What are some of the causes? You may have certain drugs, especially antiarrhythmic drugs, yes, sedative drugs, antidepressants like tricyclic antidepressants, even antihypertensive and other vasodilators, and antianginal drugs. You may also have peripheral neuropathy, diabetic, alcoholic, nutritional, and even amyloid. It may be idiopathic postural hypotension, or we don't really know the cause, multisystemic atrophies, even physical deconditioning. You may have a decrease in blood volume, hypovolemia, which may be attributed to diarrhea, burns, hemorrhage, diuresis, adrenal insufficiency, a ruptured ectopic pregnancy, abdominal aortic aneurysm. Then it may be due to decrease in peripheral resistance, which is as a result of autonomic dysfunction in diabetes mellitus, Parkinson's, multiple system atrophy, amyloidosis, Addison's disease, even with pheochromocytomas. Now, what are the types of syncope? I think I've alluded to this already. You have the neurocardiogenic or the vasovagal syncope, which is due to sudden reflex bradycardia, vasodilatation of the peripheral or the splanchnic vasculature. It is seen in childhood, in youth, and in pregnant individuals. You may have the cardiac syncope, which are the Stokes-Adams attacks. These are potentially serious and often treatable, so there is little or no warning. This can happen when the patient is even lying down flat. They are attributed mostly to cardiac arrhythmias, so the heart blocks, the left ventricular outflow obstruction can cause this, and syncope during exercise actually is a feature that's going to be pointing towards cardiac origin. You may sometimes have situational syncope, which could be micturition during urinating, especially in men at night, cough syncope during coughing, because remember that when the venous return to the heart is obstructed by bouts of severe coughing, this actually can even also happen with laughter, and the patient can actually faint. You may have postural hypotension, which can cause syncope and occurs in elderly Patients in autonomic neuropathies and even in some drugs like antihypertensive, carotid sinus hypersensitivity, which is of course due to vagal response caused by pressure over the collar or pressure over the carotid sinus baroreceptors in the neck. This is maybe due to a tight neck collar. Then you may also have convulsive syncope, which I didn't talk about. So this is collapsing in a propped up position following a syncope. Then this is going to be actually resulting in a delay in restoration, or as a result of the syncope, there's going to be delay in restoration of cerebral blood flow, and this may actually result in secondary anoxic seizures. So someone can faint because the blood supply to the brain has been impaired, and then this may lead to a seizure. So what's our approach to the patient? So we pretty much want to get a history. So a normal history and a normal physical examination suggests that this patient could have a vasodepressor or a neurocardiogenic syncope in 50% of the patient. So do a tilt table test if it's recurrent. If the history suggests that there's cardiac disease, physical examination is abnormal, then this is going to be suggesting cardiogenic syncope. So in ECG and echocardiograph, 24-hour monitoring of the ECG can be done. Then if the examination reveals orthostatic hypotension, we should review the medication. Generally, if there is a normal neurologic examination, consider postganglionic autonomic insufficiency. So pharmacological evaluation of the autonomic function should be done. Then if it's abnormal neurological examination, then consider peripheral neuropathy like diabetes, nutritional amyloid. Then of course, in the central nervous system findings, you should consider multiple system atrophies. Now here is the other differential diagnosis and how to distinguish between them and syncope. So with the non-epileptic attacks or the non-epileptic disorder, your pseudo seizures. So generally there's going to be these are regularly causing difficulty in diagnosis. The attacks may look like a grand mal seizure, and usually they are bizarre thrashing, non-synchronous limb movements, but they can actually be extremely difficult in separating these attacks from seizures. So an EEG can actually be done, and apparently status epilepticus can actually happen. Then the serum prolactin levels are of some value. They may be raised in a grand mal seizure, but not during a pseudo seizure or even a partial seizure. Then sometimes it could be a panic attack. These are often triggered by sudden sympathetic activation or often hyperventilation that is leading to respiratory alkalosis that turns off the centers in your brain. Then the symptoms are going to be dizziness, chest pains or chest tightness, a feeling of choking, shortness of breath, tingling in the face and even in the extremities, palpitations, trembling, and even a feeling of dissociation or a feeling of impending doom. There may be consciousness which is usually preserved, and the attacks are easily recognized. Sometimes it can be hypoglycemia, hunger. So there is some confusion that's followed by loss of consciousness, sometimes with a convulsion, a dysphagia. You may also have hemiparesis. There is often some warning signs with hunger, malaise, shaking, sweating, and of course there's prompt recovery once you give this patient's oral or even IV glucose. So prolonged hypoglycemia can actually cause widespread cerebral damage. That's hypoglycemic induced brain trauma, and hypoglycemic attacks unrelated to diabetes are actually quite rare. So the feeling of faint after fasting does not actually indicate anything serious. It's pretty much normal. And it may be vertigo, which when acute, vertigo can actually be sufficiently severe to cause prostration. So a few seconds of unresponsiveness sometimes can follow. Migraines can also happen. So with severe basilar migraines and familial hemiplegia, migraines may actually occasionally lead to loss of consciousness. You may also have the transient ischemic attacks, which almost never cause loss of consciousness. Then you may also have hypocalcemia, which is with the grand mal seizure that may accompany hypocalcemia. So the seizure threshold is actually lowered when patients have hypocalcemia. Then other things to consider, you may consider hyperventilation, drop attacks, hydrocephalic attacks, basilar migraines, severe vertigo, cataplexy, narcolepsy, as well as sleep paralysis. Now, what's the management of these patients? Now, remember that management is dependent on the underlying cause. So we want to provide first aid by generally giving some advice to the patients who have fainted. So lay the patient flat on a flat surface, remove any ties, remove any necklaces. If they have a tight collar, remove the tight collar, remove the shoes or anything that can be strangulating the patient. Check this patient's blood sugar, check their vitals, check their pupillary response to light. Elevate their legs above the head. So when the patient actually recovers, take a full history, a full physical examination in order for investigations to determine the underlying cause. Here's a mnemonic to help you on the history: bad balance. So what happened before, after, and during the syncope? Have they banged their head? Is there any head injury? Are there any arrhythmic symptoms like palpitation, chest pain, loss of consciousness, or do they remember the fall? Is there any history of alcohol? Have they been drinking? New medication that they have been taking? Take a collateral history from an observer, and has this ever happened before? So bad balance, or you can remember balance. Bad for before, after, and during, and balance for the rest of these. So in cases of benign causes, reassure the patient and tell them to avoid any triggers. General advice to the patient on maneuvers to prevent a faint. Educate them on this. So there are some warning signs, the pre-syncope attacks that they may feel before they faint. Tell them to avoid wearing tight clothing around the neck. Avoid standing in a fixed place. So if they're standing, they should move their toes in their shoes and walk around a bit to prevent them from fainting. And wear also tight socks that can actually squeeze the calf muscles and push blood back to the heart. Then if they are feeling dizzy, they should actually sit down or lay down flat, and actually they may sit on the chair or even against the wall, and they may actually even tuck their head in between their knees. This can actually help them prevent a faint. Then avoid hypoglycemia for extended periods, and they should always keep hydrated. Now, what's the admission criteria? If there's any risk factor for a cardiac syncope that are present, admit the patient. If syncope is suspected to be secondary to an arrhythmic attack or even obstructive or even low cardiac output, admit the patient. Because remember that patients with cardiogenic syncope are at increased risk of sudden death. Complications usually and prognosis depend on the underlying cause. Generally, there is a good prognosis in the typical vasovagal syncope attacks. Now, here's the last slide to distinguish between syncope and generalized tonic-clonic seizures. Remember that syncope is going to have some precipitating factors, so emotional stress, force of a maneuver, for example. Generally, there are none with seizures. You may also sometimes have some precipitating factors like the flashing lights, but generally in most patients you won't even, there may be, if they're having epilepsy, there may not be any trigger. Then the premonitory symptoms, they are usually none or vague, and seizures, usually you get tunnel vision, lethargy, nausea, diaphoresis with syncope, and seizures can occur at any position. Syncope occurs generally in the standing position. Transition to unconsciousness is immediate with seizures. It's gradual over seconds and usually preceded by premonitory symptoms in syncope. Then, of course, the duration of consciousness is about minutes in seizures, seconds in syncope. The duration of the tonic or clonic movements, 30 to 60 seconds in seizures, less than 15 seconds in syncope. Then the appearance is usually cyanotic in seizures, pallor-like in syncope. Then post-event confusion and lethargy usually takes minutes to hours. Here, if it's present, it's less than 5 minutes. Tongue biting usually occurs in seizures. It's rare in syncope. Incontinence occurs in both. Then elevated creatinine phosphokinase is frequently seen with the seizures. It's rare. It's occasionally seen with the syncope. Here's a warm-up OSCE station. A 25-year-old girl presents to the emergency department with episodes of syncope. Take a history, ask important questions that will help you enable you to make a diagnosis. So if it's a physical OSCE station, greet the patient, introduce yourself, gain consent. Hi, my name is Moses. I've been asked to take a history that I've heard that you're fainted. Is that okay with you? Can I confirm that your name is Grace Perry and you're 25 years old? Okay, fine. Then go on to ask about the onset, the duration of fainting, and the frequency, the events before, during, and after the episode. And of course, the position of the patient at the time of syncope. Were they walking? Were they seated? Were they standing? Collateral history based on the abnormal movements during the loss of consciousness and possible history of injury. Is there any presence of the warning signs, the dizziness, the nausea, the profuse sweating, precipitating factors like exertion, swallowing, or even bowel movements? Is there any associated symptoms like palpitations, tachycardia, panic episodes, hyperventilation? And what are the events that preceded the syncope? Head turning or even a tight necktie if they were wearing a necktie. If it's a girl who likes wearing neckties for some reason, or even a tight necklace, then were they micturating shaving? And shaving wouldn't be, I don't think girls shave their necks. I don't know. Anyways, coughing. And then if there is a family history of sudden death, and the drugs that they're taking, if they're taking any beta blockers, digoxin, antidepressants, or antiarrhythmic drugs, ask for the last menstrual history, the last menstrual period. and if they're taking a pregnancy test, the past history of diabetes, hypertension, ischemic heart disease, and even epilepsy, past surgical history of a pacemaker insertion or any cardiac surgeries, history of smoking, and history of drinking alcohol. Then, of course, thank the patient and offer a few investigations if they do ask you about investigations, and they may sometimes even ask you about what the cause may be. I really hope you enjoyed listening to this lecture about syncope. If you did, consider subscribing to the channel. Hit the bell notification icon to never miss such content on the channel. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.